Hello, future nurses. This is Professor Flourish. Today we are going to be talking about we're going to be talking about the medications that we use with our GI system. So as always, we're going to start with a general GI overview. So on that, what I have is your upper esophageal sphincter and your lower esophageal sphincter. So these are two sphincters, and basically the way they work is they will open and close. And the idea behind that is your upper esophageal sphincter is supposed to prevent aspiration of contents. So it'll open and close in hopes to keeping those contents from being aspirated. The lower esophageal sphincters separates gastric contents from the esophagus. So that basically keeps that stomach acid within the stomach itself here. Um, these gastric contents are very acidic and can harm the esophageal epithelium. The next thing you've got is gastric parietal cells. These secrete hydrochloric acid and the intrinsic factor. So your intrinsic factor is used with vitamin B12 to help create some of your RBCs. Like it helps with a certain aspect of that. So if you were to remove part of the stomach, or if you were to be born without an intrinsic factor, then you would have a deficiency in B12, which would mean that you'd become anemic. So that's why we get concerned with people who have gastric bypass surgery about that intrinsic factor. Your gastric goblet cells secrete mucus and prostaglandins to protect the stomach lining from harsh acids. Next, we've got the small intestine villi and microvilli. So it's very similar to those finger-like projections that you would see in the respiratory system. Basically, these contain goblet cells. So they release digestive enzymes, secrete mucus, and they absorb those nutrients. So the villi and the microvilli double the surface area, significantly increasing that absorption capacity of the small intestine. You've got the duodenum, and then you've got the duodenum, which absorbs amino acids, glucose, iron, calcium, fat-soluble vitamins A, D, E, and K. And then you have the ileum, which is the last and longest segment of the small intestine. Once again, you can have that reabsorption of vitamin B12 and the return of bile acids to the liver. So if you have a gastric bypass, or if you were to remove part of the small intestine, both those things would affect your ability to have that vitamin B12. So it's uh, so now we're getting into the large intestine. So the idea behind the large intestine is that it absorbs water and salt and stores feces until you're ready to defecate. You've got the cuculum, which is a pouch that projects downward at the junction of the ileum, portion of the small intestine and colon. We've got the appendix, the ascending colon, which you can see going up through this way, ascending colon, transverse colon. It always reminds me of a T because it looks like the top of a T. Descending colon, sigmoid colon, the rectum, and the anal canal. Basically, what happens is somebody eats something, it goes to the esophagus, to the stomach, all the way through the small intestines, until finally it gets up through the ascending colon, transverse colon, descending colon, sigmoid, rectum, and then finally anal canal, where it's excreted. With this, when you get into the ileostomy, or not ileostomies, colostomies, depending on the location is what kind of colostomy you'll have, which is kind of a helpful thing. Your large bowel function, so normal flora bacteria breaks down proteins that were not digested or absorbed in the small intestine. These resulting amino acids are broken down by bacteria, which leaves ammonia. Ammonia is carried to the liver and then converted to urea. Bacteria converted unabsorbed carbohydrates into absorbable organic acids. And then that bacteria metabolizes bile salts and facilitates the absorption of bile. So that's kind of what your large bowel does. Your physical examination of the abdomen, we've got inspection, auscultation, percussion, palpation. So with your examination of the abdomen, you do want to inspect and listen before you actually do percussion or palpate. The reason for that is because you can actually disrupt the GI system, and they might accidentally think that there's more frequency than there might be. These are just some more kind of helpful hints with it, especially when you get into your med surg classes. Your right lower quadrant tenderness usually indicates appendicitis. A digital exam may also demonstrate hard stool in the rectum with fecal impaction. Left lower quadrant tenderness is usually diverticulitis. Right upper quadrant tenderness is usually a Murphy sign, which is associated with your gallbladder. A stool sample should be obtained for fecal occult blood testing if they notice any of that melena. So if there's any sign of blood in the stool. So your health history of large bowel function, you want the quality of pain, abdominal pain, cramping, nausea, vomiting, excessive gas, rectal fullness, colicky pain, intense abdominal pain that occurs in waves. It's usually often a characteristic of large bowel disorders. Frequency, amount, timing of normal defecation, and any recent change. Amount, consistency, and color of stool. The type of diet, use of laxatives, enemas, and drug use. And then distinction between a complete bowel obstruction from a partial obstruction. Partial obstruction is less urgent condition than a complete obstruction. So that's just some general health history to think about. So your acid-related diseases and drugs. So these are, so all that we went over is kind of like the norms. Now we're getting into abnormal. So we can have different acid-related diseases. So you've got your peptic ulcer disease, which is gastric or duodenal ulcers that involve digestion of the GI mucosa by enzyme pepsid. And then you've got your Helicobacter pylori, which is your H. pylori. And this is the bacterium found in GI tract of 90% of the patients with duodenal ulcers. First-line therapy includes a 10 to 14-day course of proton pump inhibitors and the antibiotics clarithromycin and either amoxicillin or metronidazole or a combination. So usually H. pylori is that bacteria that will lead into those peptic ulcers. You can have stress-related mucosa damage. So GI lesions are commonly found in intensive care patients, especially within the first 24 hours after admissions. Some of the factors for that include decreased blood flow, mucosal ischemia, perforation, and reperforation injury. So basically with our ICU patients, we kind of lay them in a bed and we don't really have them move very much. So they're losing that capability of having that increased motility. So it's going to disrupt their stomach acid. NG tubes and ventilators predispose patients to GI bleeding. A histamine receptor blocking drug or a PPI, that's that proton pump inhibitor, are usually given for prevention. So data does not support the continued use of stress ulcer prophylactics after the patient is no longer in the ICU. So usually we will do all the stress ulcer prophylactics while they're in the ICU, but once they leave, it's a little less so. So the types of acid controlling drugs we have are antacids, our histamine 2 blockers, so our H2 antagonists, and our proton pump inhibitors. So we talked about our H2, antagonists last week, and now we're just getting back into those. Our antacids, so basic components used to neutralize stomach acid. So these can be salts of aluminum, magnesium, calcium, and or sodium. Many antacid preparations also contain the anti-fluctuant, so anti-gas drug simethicone. So sometimes you'll have simethicone with an antacid. And the idea behind that is I'm going to lower my acids as well as lower how much gas the patient has. Many aluminum and calcium-based formations also include magnesium, which not only contributes to the acid neutralizing capacity, but also counteracts the constipating effects. So that kind of helps with that. Calcium antacids may lead to the development of kidney stones and increased gastric acid secretion. So you do want to watch for patients that take a lot of these calcium antacids that they're not developing kidney stones. Antacids containing magnesium must be avoided in patients with renal failure. So that's a counterindication. Sodium bicarbonate is highly soluble antacid form with a quick onset with short duration of action. So that's more like our intensive care medication. So the mechanism of action, they do not prevent the overproduction of acid, but instead help to neutralize acid secretions. So basically, the way antacids work is they're going to neutralize things. So if you've got too much acid, we're going to give you something to balance it. We're going to give you some sort of base. And in a nutshell, that's how they work. They can promote gastric mucosal defense mechanisms and stimulate the secretion of mucus, bicarbonate, and prostaglandins. So mucus is the protective barrier against HCl. Bicarbonate helps buffer the acidic properties of your stomach acid, and prostaglandins prevent the activation of proton pump. Your drug effects should be reduction of pain associated with acid-related disorders, rising the gastric pH 1 point, neutralizing 90% of that gastric acid. Reducing acidity reduces pain as a result of base-mediated inhibition of the protein digestion ability of pepsid, increase the resistance of the stomach lining to irritation, and increase the tone of cardiac sphincter. Indications, so why we would use it, acute relief symptoms associated with peptic ulcers, gastritis, gastric hyperacidity, and heartburn. Some of your counterindications are any allergy to known drug, severe renal, because remember, especially with your magnesium ones, it can potentially be toxic accumulation of those electrolytes. GI absorption or obstruction, antacids may stimulate GI motility. So if you've got that obstruction, you don't actually want anything that's going to stimulate the motility. So just watching for that because it can end up requiring surgical intervention. So some of the over-the-counter medications available are things like capsules, tablets, powders, chewable, suspension, those granules, and tablets. So they can be used alone or in combination. So you've got aluminum salts, magnesium salts, calcium salts, sodium bicarbonate. Your aluminum salts have that constipating effect, often used with magnesium to counteract constipation, often recommended for patients with renal disease, so easily excreted. And then I've got some examples on there. So things like your Malax, that kind of antacid. Magnesium salts commonly cause diarrhea, usually used with other drugs to counteract this effect. Dangerous when used with a renal failure patient, and the failing kidney cannot excrete extra magnesium, resulting in accumulation. So you do want to be careful with your antacids, especially magnesium ones, that you're not giving it to that renal patient. Some of your examples are your hydroxine salt, your carbonate salt, your combination products, again, where we can have it where it's aluminum and magnesium. Your calcium salts, remember this can form kidney stones, so watching for that. Many forms, but carbonate is the most common. It may cause constipation and kidney stones. So when you're studying these, try to get into your head which ones cause constipation, which ones cause diarrhea. It's not recommended for patients with renal disease. Long duration of acid action may cause increased gastric and acid secretions. So they may have that hyperacidity rebound effect. And you can use this sometimes as an extra dietary source of dietary calcium. And an example of that is Tums or your calcium carbonate. Your sodium bicarbonate is highly soluble, buffers the acidic properties of your hydrochloric acid. Quick onset but short duration may cause metabolic alkalosis, and sodium content may cause problems in patients with heart failure. So you want to watch your heart failure patients, so your heart patients, your hypertension patients, and your renal insufficiency. And like I said, sodium bicarbonate is usually used for patients that are in intensive care. They're going through metabolic acidosis, and we just need to kind of fix the problem. Antacid and anti-fluctuants. So your anti-fluctuant, your anti-gas medications. Sorry, I thought somebody was coming in here. It's used to relieve the painful symptoms associated with gas. Several drugs are used to bind to alter intestinal gas and are often added to antacid combination products. So that's where that simethicone comes from. So simethicone, you'll usually see this anti-gas medication in association with your antacids. So if you overuse your antacids, you can cause metabolic alkalosis. With aluminum and calcium, it's constipation, magnesium, diarrhea. Your calcium antacids, kidney stones, rebound, hyperacidity. Calcium carbonate produces gas and belching, often combined with simethicone to help with that. So that's kind of like a quick little overview of those ones. Drug interactions, absorption of other drugs to antacids reduces the ability of other drugs to be absorbed in the body. Chelation, chemical binding or inactivation of other drugs, produces insoluble complexes, so you can have reduced drug absorption with these. Your drug interactions increase stomach pH, increase absorption of basic drugs, decrease absorption of acidic drugs. Increase urinary pH, increase excretion of acidic drugs, and decrease excretion of basic drugs. So you do want to be careful with your antacids because it can change both the pH of your stomach as well as your urinary tract. So here are our H2 receptor antagonists. They reduce acid secretion. They're available over the counter in lower dosage forms. Some of the most popular drugs for treatment of acid-related disorders. So we've got that cimetidine, niazidine, famotidine, ranitidine. So they all kind of end in this tidine. They competitively block the H2 receptors of acid-producing parietal cells, reduce hydrogen ion secretion from parietal cells, increase in the pH of the stomach, relief of many of the symptoms associated with these hyperacidity related conditions. So when you're studying your antihistamines, your H2 antihistamines are all kind of your GI ones. So it's blocking those acid producing parietal cells. Drug effect is to the suppression and secretions in the stomach. Indication can be things like your gastroesophageal reflux disease, your peptic ulcer diseases, your erosive esophagitis, adjunct therapy to control upper GI bleed, Zollinger-Ellison syndrome. So all these kind of ones where we've got overproduction of acid. Overall, very few adverse effects. They do have some central nervous system adverse effects in the elderly, which may look like confusion or disorientation. Cimetidine may induce impotence and gendoechimastia, which is basically the development of breast in a male patient. Thrombocytopenia has been reported in ranitidine and famotidine. So cimetidine binds with P45 microsomul oxidase system in the liver, which results in inhibiting oxidation of many drugs and increased drug levels. All H2 antagonists may inhibit the absorption of drugs that require an acidic GI environment for absorption. Because of its potential to cause drug interactions, cimetidine has been largely replaced by ranitidine and famotidine. Cimetidine is still used for treat certain allergic reactions, though. Smoking has been shown to decrease the effectiveness of H2 blockers. So that's kind of like an important thing that they understand, that they may not get relief for their stomach issue if they are smoking. For optimal results, H2 receptor antagonists are taken 1 to 2 hours before antacids. Okay, so when working with a patient who has been admitted for possible GI bleed, the nurse identifies which drug as having the potential to cause confusion and disorientation. So when we think about it, what one of these classes did we talk about that could potentially cause an issue with confusion? Antacids don't cause confusion. Your proton pump inhibitors aren't. But yes, an H2 antagonist, because remember, they also have those antihistamine results. So in your older adults, it can cause confusion or disorientation. Okay, so our protein pump inhibitors, the parietal cells release positive hydron ions during hydrochloric acid production. This process is called the proton pump. H2 blockers and antihistamines do not stop the action of this pump. So they're not going to stop the action of this pump. You have to have a proton pump inhibitor. And these are all our lovely protein pump inhibitors. So they're going to irreversibly bind to H plus, K plus, ATP enzymes. This bond prevents the movement of hydrogen ions from parietal cells into the stomach, results in achlorohydria. All gastric acid secretions is temporarily blocked. To return to normal acid secretion, parietal cells must synthesize new H plus, K plus ATPs. It's indicated for GERD, erosive esophagitis, short-term treatment of active duodenal and benign gastric ulcers, Zollinger's Ellison syndrome, your NSAID-induced ulcers, stress ulcer prophylactics, and treatment of H. pylori-induced ulcers. So that's usually given with an antibiotic. They're generally well tolerated. So there is a possible predisposition of the GI tract infections, so they can get C. diff as one of their adverse effects. They're more likely to develop C. diff. Osteoporosis and risk of wrist, hip, and spine fractures in long-term users. Pneumonia, depletion of magnesium, link between PPIs and dementia, as well as development of lupus erythematosus. So the drug interactions, they can increase the serum levels of diazepam and phenytoin. Warfarin increases the chance of bleeding, absorption of ketoconazole, ampicillin, iron salts, and digoxin. It does also interact with clopidogrel. Sucralfate may delay the absorption of PPIs, and food may decrease the absorption of DTIs or PPIs. Miscellaneous acid controlling drugs are your Carfate, your misoprostol, and your simethicone. So Carfate, cytoprotective drug used for stress ulcers, peptic ulcer disease, attracted to and binds to the base of ulcers and erosions, forming a protective barrier over the areas. Protects these areas from pepsin, which normally breaks down proteins, so making the ulcers worse. Little absorption from the gut. They may cause constipation, nausea, and dry mouth. May impair absorption of other drugs. So you usually give other drugs at least 2 hours before. You do not administer with other drugs, and it binds with phosphate. So may be used in chronic renal failure to reduce phosphate levels. Your prostaglandin E analog. So this is your misoprostol. So we've talked about this one before. So this should be a refresher. Prostaglandins have cytoprotective activity. So these protect against, these protect gastric mucosa from injury by enhancing local production of mucus or bicarbonate, promote local cell regeneration, and help to maintain mucosal blood flow. So that's how misoprostol works. We usually use it for the prevention of NSAID-induced gastric ulcers. Doses that are therapeutic enough to treat duodenal ulcers often produce abdominal cramps and diarrhea. So these are usually used more for that prevention. Simethicone is your anti-gas drug. It's used to reduce the discomforts of gastric or intestinal gas, alters elasticity of mucus-coated gas bubbles, breaking them into smaller ones. And the result is decreased gas pains and increased exocclusion via the mouth or rectum. So some of your nursing implications for antacids. You want to assess for allergies and pre-existing conditions. Patients with heart failure, hypertension should not use antacids with high sodium content. So the main thing about your antacids is make sure that you know what kind of antacid it is and what's going on with your patient. Because if you're a heart failure patient, you probably want to avoid things like your sodium-based antacid. If you got a patient who's got really bad renal problems, you probably don't want to give them a magnesium antacid. So they do have many drug interactions, so just be careful. And you should administer medications 1 to 2 hours after an antacid, and they may cause premature dissolving of enteric-coated medications, resulting in stomach upset. Be sure that the chewable tablets are chewed thoroughly and liquid forms are shaken well before giving. Administer with at least 8 ounces of water to enhance absorption, except for those rapid dissolve forms. Long-term self-medication with antacid may mask symptoms of a serious underlying disease, such as malignancy or bleeding ulcers. If symptoms remain ongoing, the patient should seek medical evaluation. Monitor for adverse effects, so things like nausea, vomiting, abnormal pain, diarrhea. With calcium-containing products, looking for that constipation and acid rebound. And you just want to let the provider know if symptoms are not relieved. So with your H2 antagonist, you want to assess for allergies, impaired renal or liver function. You want to use cautiously with patients who are confused, disoriented, or older. Because remember, with these antihistamines, it can cause your older patient to become confused. Take 1 to 2 hours before antacid. For IV uses, follow those administration guidelines. For your protein pump inhibitors, assess for allergies and history of liver disease. Not all are available for that peritoneal administration. May increase serum levels of diazepam and phenytoin. May increase chance for bleeding with warfarin. So the granules of potidine capsules may be given via NG tubes, but the NG tube must be at least 16 gauge or the tube may become clogged. So just be careful when you're giving those granules because they do get stuck in the GI tube, especially if you're trying to use a small GI tube. Capsule contents may be opened and mixed with applesauce, but do not chew or crush delayed release granules. All right, so our bowel disorder drugs. So we've got diarrhea, which is an abnormal passage of stools with increased frequency, fluidity, and weight, or with increased stool water excretion. Acute diarrhea is sudden in onset, usually lasts 3 days to 2 weeks, self-limiting, and usually can resolve without needing anything. Chronic diarrhea lasts for more than 3 to 4 weeks, associated with that reoccurring passage of diarrheal stools, fever, loss of appetite, nausea, vomiting, weight loss, and chronic weakness. So here's just a list of things that can cause acute diarrhea. So it can be drug-induced. It can be anything from a protozoal to a bacteria to a virus, and it can even be something that you ate that just makes you have diarrhea. Chronic diarrhea can be caused by things like tumors, diabetes mellitus, Addison's disease, hyperthyroidism, irritable bowel syndrome, and AIDS. So your goal of diarrhea treatment is stopping the stool frequency, alleviating the abdominal cramps, replenishing fluids and electrolytes, and preventing weight loss and nutritional deficits from malabsorption. Antidiarrheals, we've got adsorbents, anti-motility drugs. So those are things like our anticholinergic and our opiates, and probiotics, also known as intestinal flora modifiers and bacterial replacement drugs. So adsorbents, basically what they do is they coat the GI tract. They bind to causative bacteria or toxin, which is then eliminated through the stool. So examples are things like your Pepto-Bismol, so bismuth subsalicylate, activated charcoal, anti-lipidemic drugs, colostranum. Your anti-motility drugs are your anticholinergic drugs. They decrease intestinal mucosis tone and basically that movement to your peristalsis of the GI tract results in the slowing of the movement of fecal matter through the GI tract. And your example may be your belladonna alkaloids. Your opiates decrease bowel motility and reduce pain by relief of rectal spasms. They decrease the transit time through the bowel, allowing more time for water and electrolytes to be absorbed. So some of those are things like your codeine that we talked about before. Anticholinergics, mechanism of action. Did I go back? I think I went backwards today. Well, talk about it again. So these slow, like I said before, they have that drying effect, reduce gastric secretions, using combination with absorbents and opiates. All right, so now I know what I was thinking. So these belladonna alkaloids are anticholinergic slash antispasmatics. So they will stop it from spazzing. Okay. Your probiotics, also known as intestinal flora modifiers and bacterial replacement drugs, they work by supplying missing bacteria in the GI tract. So basically what happens is we got rid of all of the good organisms. So now we're going to give them something that can help. Suppresses the growth of diarrhea causing bacteria. So I'm giving the good bacteria to kind of outweigh the bad bacteria. So your indication, your absorbents, milder cases, your anticholinergic and opiates, more severe cases, probiotics, antibiotic-induced diarrhea. Adverse effects, your absorbents can increase bleeding time, constipation, dark stools, confusion, tinnitus, metallic taste, and blue tongue. Anticholinergics, urinary retention, impotence, headache, dizziness, confusion, anxiety, drowsiness, confusion, dry skin, flushing, blurred vision, hypotension, bradycardia. Opiates are things like drowsiness, dizziness, lethargicness, nausea, vomiting, constipation, respiratory depression, hypotension, urinary retention, and flushing. And then your interactions, your absorbents decrease the absorption of many drugs, including digoxin, quinidine, hypoglycemic drugs. Absorptions cause increased bleeding time and bruising when given with warfarin. Toxic effects of methotrexate are likely when given with absorbents. And that methotrexate is one of those drugs for your rheumatoid arthritis. Nursing implication, you want a thorough history. And you don't want to give Pepto-Bismol, so that bismuth subsalicylate, to children or teenagers with chickenpox or influenza because of that risk for Reye syndrome. Because Reye syndrome comes from that salicylate, so you just want to make sure you're watching for that. Use absorbents carefully in older adults and those with decreased bleeding time. Do not administer anticholinergic to patients with a history of narrow angle glaucoma, GI obstruction, myasthenia gravis, paralytic ileus, or toxic megalocolon. Teach patients to take medications directly as it's prescribed. Assess fluid volume status, ins and outs, mucosal membranes before, during, and after initiation of treatment. Teach patients to notify their prescribers immediately if symptoms persist and monitor for those therapeutic effects. For constipation, abnormally infrequent and difficult passage of feces through the lower GI tract. It is a symptom, not a disease. It's that disorder of movement through the colon or rectum and can be caused by a variety of diseases or drugs. So your treatment can be surgical. So if they got complete obstruction, then we might actually have to pull it out surgically. Non-surgically, dietary, so fiber, supplementation, behavioral, so increased physical activity, and pharmaceutical. So we've got different types of laxatives. We've got things like our bulk forming. We've got emollient, which is your stool softeners, lubricant laxatives, hyperosmotic, saline, and stimulant. Bulk forming are your high fiber. They absorb water to increase bulk, distant bowel to initiate reflex bowel activity. And some of your examples are your xylilium and methacillose. Your emollient are your stool softeners and lubricants. They promote more water and fat in the stool, lubricate the fecal matter and intestinal walls. So that would be like your ducasate salts, and your lubricants would be things like your mineral oil. Okay. So your hyperosmotic, increased fecal water content, results in bowel distension, increased peristalsis, and evacuation. Examples are things like your polyethylene glycol, lactulose. Now with lactulose, while it is a hyperosmotic laxative, we use it more for the reduction of ammonia. So if you see it ordered on somebody, it's not always just ordered to make them have a laxative. It's a lot of times ordered for hepatic encephalopathy, which basically means that I've got a liver patient who is a heavy alcoholic a lot of times, and they have all this ammonia that's built up, goes to their brain. I need to get that ammonia out, so I give them lactulose and they poop it out. Saline increased osmotic pressure within the intestinal tract, causing more water to enter the intestines, results in bowel obstruction or bowel distension, increase peristalsis and evacuation. Examples are our milk of magnesium and our magnesium citrate. Stimulate, increase peristalsis via intestinal nerve stimulation. So these would be things like our senna or our bizocoline. Peripherally acting opioid antagonist. Treatment of constipation related to opioid use in bowel resection therapy, block entrance of opioid into the bowel, strict regulation for use. So you really you have to have an order for most of these, but these ones are like you only use it when you really have to use it. So it does allow the bowel to function normally with continued opioid use. For some of them, the strict regulation for use, it depends on which one you're giving, because some of these do require them to be given while they're in the hospital, just so you can watch them while you give that. So this is just some indications like your bulk forming, your emollient. Hyperosmotic, saline, stimulant. So they've kind of all got their uses on there. Bulk forming, adverse effects, impaction, because if you don't give it with water, then it can end up becoming just kind of stuck there. Fluid overload, electrolyte imbalances, esophageal blockade, emollient, skin rashes, decreased absorption of vitamins, electrolyte imbalances, and lipid pneumonia. Hyperosmotic, abdominal bloating, electrolyte imbalances, rectal irritation. Saline and magnesium toxicity, cramping, electrolyte imbalances, diarrhea, increased thirst. Stimulant, nutrition, malabsorption, skin rashes, gastric irritation, electrolyte imbalances, discolored urine, rectal irritation. And no matter which laxative it is, they all do cause electrolyte imbalances. So with them, you want to get that thorough history again. You want to look at their fluid and electrolytes, inform them not to take a laxative if they are experiencing nausea, vomiting, or abdominal pain. A healthy high fiber diet and increased fluid intake should be encouraged as that alternative for laxative use. Long-term use of laxatives often results in decreased bowel tone and may lead to dependency. So you don't want them to be on laxatives to the end of time. All laxatives tablets should be swallowed whole, not crushed or chewed, especially if enteric coated. Patients should take all laxative tablets with 6 to 8 ounces of water, and they should take bulk forming laxatives as directed by manufacturer with at least 240 mLs of water. You want to give mischoline with water because of interactions with milk, antacids, and juice. You want to inform patients to contact their prescribers if they experience severe abdominal pain, muscle weakness, cramps, or dizziness, and monitor for therapeutic effects. So with your irritable bowel syndrome is that chronic intestinal discomfort, which is usually seen by cramps, diarrhea, or constipation. Usually they can control their symptoms by just avoiding irritating food or taking over the counter laxatives and antidiarrheal drugs. Some of the drugs are your tagaceroid, lubiprostone, or allosterone. So nursing implications, you just want to perform a general assessment, follow administration guidelines, and assess for that therapeutic response. So your anti-epidemic and anti-nausea medications. So these are the medications that keep us from vomiting or keep us from becoming nauseous. So nausea is just that unpleasant feeling that often precedes vomiting. Emesis is your vomiting. So that's that forceful emptying of the gastric and occasionally intestinal contents. Anti-epidic is used to relieve nausea and vomiting. So vomiting center and chemoreceptor trigger zone. So your vomiting center and your chemoreceptor trigger zone are both located in the brain. Once stimulated, they can cause that vomiting reflex. So you can have different types of nausea and vomiting. Some can be from chemotherapy induced, so that's why you usually give it 60 to 90 minutes before they have their chemotherapy. It can be things like post-operatively or just in general. So these are all the different types of medications we can have: anticholinergic, antihistamine, antidopaminic drugs, neurokine antagonists, protokinetic drugs, serotonin blockers, terahydrocannabinoids. They have a lot of different mechanisms of action. Most work by blocking one of the vomiting pathways, thus blocking the stimulus that induces vomiting. Indications vary per class. General use for each type is prevention or reduction of nausea and vomiting. Your anticholinergic drugs bind to and block acetylcholine receptors in the inner ear labyrinth, block transmission of nauseating stimuli to the CTZ, also block transmission of nauseating stimuli to the reticular formation to the VC. So scopolamine is one of the examples. Antihistamine drugs inhibit acetylcholine by binding to H1 receptors, prevent cholinergic stimulation in vestibular and reticular areas, thus preventing nausea and vomiting. They can also be used for motion sickness, non-productive cough, allergy symptoms, and sedation. Your antidopaminic drugs block dopamine receptors in the CTZ, which is that what's it called? That's that chemoreceptor trigger zone. That's what I was talking about with that. They can also be used for psychotic disorders and intractable hiccups. Neurokine receptors. Inhibit substance P and neurokinin 1 receptors in the brainstem, used in conjunction with serotonin blockers and glucocorticoids. Augments the serotonin blockers and glucocorticoids to inhibit acute and delayed phases of chemotherapy-induced emesis. Prokinetic drugs block dopamine receptors in the CTZ, cause the CTC to be desensitized to impulses it receives from the gastrointestinal tract. Also stimulate that movement in the GI tract, enhancing emptying of the stomach contents. Also used for gastroesophageal reflux disease and delayed gastric emptying. So metochlopramine is an example of that, and that's usually used for long-term use, may cause irreversible tardive dyskinesia. Serotonin blockers block serotonin receptors in the GI tract, CTZ and VC, used for nausea and vomiting in patients receiving chemotherapy and for postoperative nausea and vomiting. So the one we usually use more than anything else is that aldosterone. Your tetrahydrocannabinoids, major psychoactive substances in marijuana, inhibit effects on reticular formation, thalamus, and cerebral cortex, alter mood, and the body's perception of its surroundings, which may help relieve nausea and vomiting. Used for nausea and vomiting associated with chemotherapy and for anorexia associated with weight loss in AIDS patient. So some of your miscellaneous anti-nausea drugs are your phosphorate carbohydrate solution, and that's a mint flavored solution used off-label for treatment of morning sickness. According to drug used, stem from their non-selective blockade of various receptors. Some of your herbal products are ginger, which you can use for nausea and vomiting. What I will say is ginger can increase bleeding risk with anticoagulants. So ginger a lot of times can be used for nausea and vomiting, but you just want to make sure that they're not on an anticoagulant with it. For your nursing implications, you just want to complete a nausea and vomiting history, assess current medications, assess for counterindications of potential drug interactions. And some of these drugs can cause drowsiness. So warn them about driving or performing any hazardous tasks. So taking any of these drugs with alcohol may cause severe central nervous system depression. Teach patients to change positions slowly. And for chemotherapy, they're often given that 30 to 60 minutes before chemotherapy begins, and monitor for therapeutic effects and monitor for adverse effects. All right, thank you, everyone.